Hi, my name is Joey Northern. I'm a firefighter-paramedic with the Castle Rock Fire Rescue Department, and this is my partner, Adam Gallegos. He's also a firefighter-paramedic. We're going to walk you through the process of the National Registry Advanced Airway Management Testing Skills Station. You'll walk up on a victim, and for the scenario, your patient will be unconscious, unresponsive, and not breathing. Adam's going to look, listen, and feel in the airway, looking for chest rise and fall, listening for any air passing and feeling for any air. He's also going to visualize in the airway to make sure there's no foreign objects. He's also going to readjust the patient's airway using the head tilt, chin lift method of opening an airway. Your proctor will tell you now that your patient is not breathing and that there are no foreign objects in the airway. Adam's going to measure an oropharyngeal airway from the tip of the mouth to the corner of the earlobe. He's going to invert it, and as he inserts the airway, he's going to spin it 180 degrees, which will displace the tongue off the back of the airway. At this time, Adam's going to pick the proper mask size and bag valve mask volume and create a seal on the patient's face using the CE clamp method. Using his index finger and thumb, Adam's going to create a C around the mask, and with these three fingers, it creates an E on the patient's jaw in order to get a good seal. As Adam bags our patient, we're going to listen over the lungs and we're going to listen over the epigastric area. We should hear minimal to no sounds over the stomach, and we should hear breath sounds over the right and left lungs. At this time, during the procedure, your examiner will state to you that the patient's oxygen saturation is below 85%. At this time, we're going to hook the patient up to high flow oxygen. The tubing running off the back of the bag will come into the tank, and we're going to set that at 15 liters of oxygen per minute. You'll bag for 30 seconds at the proper rate, which is 10 to 12 breaths per minute. And at that time, the proctor will take over for the BLS airway and assisted breathing while Adam prepares his equipment for oral intubation. When Adam's looking at his laryngoscope blade, he's going to make sure that the blade is secure, that the light is bright and white, and that it's not loose. When he looks at his endotracheal tube, he's going to inflate the cuff with the syringe at the proper volume. Make sure there's no air leaks around and that it's fully inflated. You can also check the pilot bulb as well. We want to make sure our stylet's in there as well. And Adam's also going to make sure he has lubrication and securing tube ties at his disposal as well. Once Adam's got all of his equipment ready and the tube is lubricated and everything's ready to go, he'll instruct his partner to hyperoxygenate the patient. What we mean by that is to increase our ventilations slightly to make sure the patient has plenty of oxygen in their blood before the procedure. So when Adam's ready, he'll tell me okay, and I'm going to take the bag valve mask off and take away the oropharyngeal airway.
Right.
When Adam inserts the laryngoscope blade into the patient's mouth, we're trying to displace the tongue, and we want to insert the blade as to take the epiglottis up off the trachea. When Adam visualizes the cords, he's going to introduce the endotracheal tube into the patient's throat, passing the black mark or just above the cuff into the patient's throat. Adam's going to secure his airway with his fingers for right now, inflate the cuff, and he's going to eject the stylet. We'll put the bag valve mask back on the tube, simply holding it with our fingers, and we want to check once more to make sure we're in the trachea and not the esophagus. We'll listen over the stomach and we'll listen over the lungs as well. Right lung and left lung. We should hear negative epigastric sounds over the stomach, and we should hear good, clear breath sounds over both right and left lungs. Other ways of confirming tube placement are moisture or mist coming up the tube, chest rise and fall. There are commercial-made devices that we use as well that show us different colors. If we're in the esophagus, it'll change a certain color. If we're in the trachea, it will change a different color. And those are based on the manufacturer. We also have waveform capnography that hooks up to our LifePak 12 monitors, and it will give you a waveform as well as a numeric value with the amount of CO2 being exchanged out of the lungs. Once we've confirmed tube placement, Adam's going to secure our airway. We have two different ways of doing it. We have a commercial-made device, and we also have a shoelace string that we can simply lark's foot and tie around, depending upon your agency. For National Registry, you won't need to secure the airway with any sort of device. If you simply verbalize it, that will be good enough. Once we have the tube in place and it's confirmed, the next thing the proctor will explain to you is that there are secretions and or vomitous fluids coming up out of the patient's mouth and up through the tube. At this point, we're going to suction the patient's airway out. Adam's going to select the right size French catheter for suctioning, and then he's going to measure. We want to measure from the carina, which is the top of the sternum, up to the end of the tube, and we want to pinch that location there as our measurement. So once Adam has it measured, we're going to hyperoxygenate our patient, just like before, give them plenty of good clean breaths, and Adam's going to suction. Suction for no more than 5 to 10 seconds, and you want to use a twisting, gentle motion coming up out of the patient's oral airway. Now you'll notice at the end of the suction tubing there are holes. Those can become clogged with vomitous or secretions or any types of fluid. It's a good idea to have sterile water to rinse out the suction tubing. We'll put our bag valve mask back on the patient's oral airway and continue oxygenating. At this time, the test procedures are done, and your examiner will tell you if there's anything else you'd like to do. And this concludes the portion of the Advanced Airway National Registry Test Exam.